I am delighted to have been invited to participate in this meeting. I think it's a wonderful meeting, and I am humbled to be able to be a part of it. Mariela, thank you so much for reaching out and inviting me. And I also want to thank Sharona and Moshe for the technical help in allowing me to participate in the way that I am. I am doubly grateful as I view this as somewhat a small way that I can show my support for a country that I love greatly. And I hope that sometime in the future I'll be able to give a talk there with you in Israel. So with that having been said, let's get right in and discuss. So the topic of my talk is flipping the switch, as I've titled it, which I just want to highlight some of the process that occurs within the body as someone is progressing from insulin resistance, which is referred to as prediabetes, towards full-on type 2 diabetes. I'm a research scientist and professor at Brigham Young University in Utah, and I'm the director of the Diabetes Research Lab. Now, in addition to my academic appointment, I am a professor. In addition to being a professor, I do have some commercial interests. Here are my disclosures. I receive royalties from the sale of a book about insulin resistance, and then I'm involved in both as a co-founder in two ventures, a low-carb meal replacement shake and an online coaching platform. Now, the main focus here really, like I said, is the transition from insulin resistance to type 2 diabetes. And by way of introducing this connection, I wanted to just clearly emphasize the fact that type 2 diabetes is a disease of insulin resistance. Not to say that there aren't other variables that are inputting here, but it is built on a foundation of insulin resistance. And so in order to understand this progression, I want to highlight insulin resistance itself. This happens to be a very direct area of research for me in my lab, but I also emphasize it simply because it is something that I believe is too relevant not to talk about, and indeed is not talked about enough. So let's start out by defining insulin resistance. What is insulin resistance? It's going to be the villain of the story that I'll be telling you, so we want to make sure we know what the villain is. In order to understand insulin resistance, let's look at insulin and then look at it from the level or through the lens of a cell itself. So here we have a cell, this big circle with an insulin receptor, so a door that only insulin can come and knock on. We have insulin receptors at every cell in the body, literally every cell, from bone cells to brain cells, from liver cells to lung cells. They all have insulin receptors. And because every cell has an insulin receptor, every cell responds to insulin, but the cells, of course, respond differently based on what the cell is and what its job is. So when insulin comes to an insulin receptor, we're just going to say, for the sake of this lecture, that there is a cellular action. Now, to create an example of this, we have glucose. Some cells, like muscle, which I'll discuss in a moment or in a bit, insulin will stimulate the uptake of glucose. So here we have glucose outside the cell, and now insulin allows the glucose to come in. Although, of course, insulin does much, much more throughout the body than just regulate glucose levels. But this is just an easy example. Now, this is when things are working right. However, based on certain insults to the cell, which I'll elaborate more on in a moment, we can have a cell that doesn't respond as well to insulin as it used to. So the action is compromised, or the cell has become insulin resistant. This could result in an increase in blood glucose, and it also is accompanied by an increase in insulin levels itself. There's a little nuance there that we'll explore more in a moment. But this is all what's happening when the cell has stopped responding as well to insulin. So what was once a polite knocking on the door of the insulin receptor now becomes a pounding as insulin is higher and more aggressive, if you will. And that is sufficient in some instances to restore the actions of insulin. But in the course of this definition, there are two things that I really want to emphasize. If insulin resistance is a coin, these are the two sides of that coin. One is the compromised insulin signaling itself. Some cells aren't responding as well as they used to the hormone insulin. And then second, the other side of the coin is that insulin levels are higher than they were before. We must understand or appreciate both of these sides of the coin that we call insulin resistance in order to understand how insulin resistance is so pivotal and fundamental to so many diseases. That isn't the topic of this lecture, of course. I want to focus more on diabetes. So with diabetes in mind, here we have an individual. Over the course of their life, they're becoming more and more diabetic. Or in other words, glucose levels are going up, because that is how we define diabetes clinically. It is based wholly on the glucose levels. Unfortunately, with this paradigm, what goes totally overlooked is insulin. And insulin is going to look something like this in the average diabetic. It starts low, and then it goes high. And then it's high for a while, and in some individuals, not all, in some individuals, it starts to taper off. But there are two time points worth highlighting. This initial period of time is the period known as prediabetes or insulin resistance. Why this state is so often undiagnosed or overlooked is because glucose is normal in the state of insulin resistance and insulin is elevated. So insulin is the more sensitive or early marker, early indicator of progression on this pathway towards type 2 diabetes. And then as you see beyond that next hashed line, we now progress eventually into frank type 2 diabetes. This is a state defined by both elevated glucose and, yes, elevated insulin. Even though we say insulin becomes insufficient in some people, we say that, but insufficient is a relative term. It simply means there's not enough insulin to keep the glucose in check. That's true, but that is not to say that insulin has become itself low. It isn't. It is often still significantly higher, multiples higher than it was before in a normal, healthy, insulin-sensitive individual. Not to say it doesn't come down a bit. It certainly can, but it's still higher than it used to be. This, nevertheless, is type 2 diabetes. But again, what I hope you take away from this is that our failure to measure insulin itself means we are failing to detect insulin resistance in its earliest stages. All right, that's what insulin resistance is, but what is its origin story? It's all the rage these days, of course, to have a movie talk about the villain and explore the villain's backstory. Well, let's do it for just a moment. Here we have that same paradigm that I presented just a moment ago. Now let's superimpose on this paradigm specific cells. I strongly contend that insulin resistance starts in our fat cells. So the fat cell is the first tissue to fall. And so the fat cell being insulin resistant is really what's going on in this first phase of this progression. And then when we start to see the changes in glucose, this is likely occurring once the insulin resistance has progressed or spilled into three other tissues: muscle, liver, and pancreatic alpha cells. And I'll go into more detail there. But again, I submit that insulin resistance starts in the fat cell. It is the first domino to fall. And then when the fat cells become insulin resistant, it then is knocking into the other tissues, spreading the insulin resistance throughout the body. Now, I'm not going to elaborate this on much more detail, but I will very briefly. The causes of insulin resistance, I believe there are three primary causes. One is chronically elevated insulin itself as a cause of insulin resistance. Second is stress, chronically elevated stress, or even acutely, and then acute or chronic inflammation. Let's go through each of these for just a moment. And I do mean just a moment. Stress is, of course, a state that is typified by these two prototypical stress hormones, cortisol and epinephrine. These are both known hormones to stimulate or to increase blood glucose levels. That's one of the key actions, especially in cortisol, but even same with epinephrine. Because they are trying to push glucose up, they are accurately referred to as insulin antagonists, because insulin is trying to push it down. As these two stress hormones continue to push up, provide an upward pressure on the glucose levels, it just means insulin has to work harder and harder. Insulin resistance, in other words. Now, in the case of inflammation, when the body experiences higher than normal levels of cytokines, it doesn't have to reach a level of sepsis, but they also create an insulin-resistant state. This is something that happens very acutely, and so insulin sensitivity starts to go down, and now we're, of course, moving ever closer towards full-on insulin resistance and diabetes. Now, with regards to the inflammation, I just wanted to highlight some of the primary inputs there. Adipocyte hypertrophy is something I'll touch on more in just a moment, but we have other environmental things, stimuli, like diesel exhaust particles and cigarette smoke. And then we have endogenous stimuli, like autoimmune disorders, for example. All of these are known to increase inflammation, which is then known to compromise insulin sensitivity. Now, to what I consider the biggest of these three variables, hyperinsulinemia. This might seem a little strange, but chronically elevated insulin results in a steady reduction in insulin sensitivity. I believe this represents what is actually a fundamental biological principle, namely that any incessant stimulus to a cell will result in a resistance to that stimulus, whether it is a hormone like insulin, and there are other examples, or whether it is a drug, or whether it is something like an antibiotic. The cells that are exposed to this stimulus become resistant to the stimulus. I strongly contend that hyperinsulinemia is one of them. And of course, throughout the lecture, I should have mentioned this a moment ago, you'll see these PMIDs. These are the PubMed IDs. I encourage anyone at any moment after the lecture to look up any of these citations as evidence of what I'm saying. Now, let's come back to this view once again. I clearly like it. I, as I already mentioned, believe that insulin resistance starts in the fat cells. So when the fat cells fall, the rest of the body isn't far behind. So let's take a moment and explore the origins of insulin resistance at the fat cell. As people, we may have two different individuals, two fellows who were roommates at university, and then they go on and get married, get desk jobs, and life settles down, if you will. As life settles down, the waistline starts to expand, and they're both gaining 10 pounds of fat per year, let's say, until they join each other for their 10-year reunion, and they're both morbidly obese. What an inglorious reunion, of course. So in this case, these two men who appear to be gaining fat at the same rate could be gaining fat in different ways. And specifically, fat tissue expands either through hypertrophy or hyperplasia. Now, there may be a little bit of both here, but it will be predominantly one or the other, hypertrophic fat growth or hyperplastic fat growth. In the case of hypertrophy, that, of course, is simply, and you all know this, this is when the individual cells themselves are getting bigger. There's no change in cell number. It's just the cell itself is expanding. In contrast with hyperplasia, it's when the cell number is changing. Cell size isn't much. This would be like fat cells that start to get a little big. Before they ever get too big, they simply recruit new fat cells to help carry the energetic burden of storing ever more fat. Now, hypertrophy of the fat cell is not a good thing. That is a bad thing, metabolically speaking. Hyperplasia of the fat cell is metabolically a good thing. In each instance, the simplest way of defining it is that the hypertrophic fat cell is getting too full, no vacancy. It is reaching a maximal dimension, and basically, and I'll come back to this in a moment, it cannot hold any more fat. In contrast, with hyperplastic fat cells, the moment a fat cell starts to grow, it can simply recruit new fat cells to help. So there's always room for more fat. In other words, there's always vacancy. Now, to highlight the role of insulin in this process itself, here's a study that, two studies in particular, and I'm showing the histology, adipose tissue histology from one of them. But what they found here is that when at the sites of insulin injection in type 1 or type 2 diabetics, the fat cells, the adipocytes, have hypertrophied several times over normal size, upwards, potentially 4 times or more in its dimensions, in its diameter, at least. So even more so with volume. And at the whole body level, this can look something like this, where the reason, of course, we tell diabetics to rotate their injection sites is to prevent the insulin from inducing such obvious adipocyte hypertrophy, as we see here in these instances of consistent injection, either on the thighs in this woman or on the belly in this unfortunate fellow. Now, back to the insulin, the fat cells. When we have a fat cell becoming insulin resistant, and that is happening on the hypertrophic side, or the hypertrophy of the fat cells, insulin is always stimulating the uptake of fats from the blood. You know, specifically the intake of activations of lipoprotein lipase and pulling lipids off of the triglyceride-rich lipoproteins. So insulin is always stimulating the uptake of fats. Usually, however, insulin is inhibiting the breakdown. In other words, it's inhibiting lipolysis, and that's why I have, you know, this sign here. In the hyperplastic fat cells, they maintain their insulin sensitivity. So insulin can always tell the fat cells to store the energy. In contrast, the hypertrophic fat cell cannot store anymore. So insulin is force-feeding the fat cell more and more fat, and insulin would attempt to tell the fat cell to not let any of it go. The hypertrophic fat cell doesn't listen. It is now leaking free fatty acids, even though insulin is trying to tell it not to. We forgive the hypertrophic fat cell because we would contend that that is its efforts to not get so big that it reaches an unhealthy or even a dangerous level that it cannot sustain its own size and becomes, say, necrotic or something like that. So the hypertrophic fat cell becomes insulin resistant and now is leaking fatty acids. But again, from the level of the fat cell, it's forgivable because it's attempting to ensure its own survival. Now, another instance of the hypertrophic fat cell attempting to ensure its own survival, but as a result hurting the rest of the body, it's when we look at blood flow. In the case of hyperplastic adipose tissue, the size of the fat cells enables healthy, normal vascularization and healthy, normal gas exchange. In contrast, with significant hypertrophy of fat cells, the fat cells are becoming increasingly too distant from capillaries, and they become hypoxic. In an effort to resolve that hypoxia, the fat cell is secreting cytokines, some of which will hopefully induce the production of new blood vessels like VEGF, or vascular endothelial growth factor. But the consequence of this throughout the body is that now we have more cytokines flowing through the blood, increasing, albeit to a subclinical state, inflammation. So if we put all these ideas together, the hypertrophic fat cell is what's becoming insulin resistant. And in the process, it is leaking free fatty acids and it is leaking pro-inflammatory cytokines. This then is spilling into the tissues downstream of the fat, as I have indicated here. And now let's go through each of these just to highlight a very brief example of what can happen. When the blood vessels are becoming insulin resistant, they've lost their dynamic nature, where insulin is normally inducing vasodilation, and now it cannot. And so the blood vessels are staying constricted when they should be dilated. This, of course, exacerbates hypertension. In the ovaries, the hyperinsulinemia and the insulin resistance in the body is inhibiting the enzyme aromatase, which is preventing these estrogen spikes that are necessary for ovulation, thereby preventing ovulation, and at the same time resulting in an excess release of androgens, causing some of the inconvenient, awkward physical manifestations that accompany PCOS. Now, when insulin resistance reaches the brain, that is thought to be a fundamental cause of Alzheimer's disease, or at least part of it, to the point that some refer to Alzheimer's disease as type 3 diabetes. That is to say, insulin resistance of the brain. When the liver becomes insulin resistant, its handling of fats, what it's making and storing, as well as what it is packaging and releasing in the form of VLDL and HDL metabolism is changed, driving dyslipidemia. When the muscle becomes insulin resistant, among other consequences, the muscle will start to become sarcopenic because of the loss of insulin protecting muscle proteins. And then lastly, on just a short list of examples, the kidneys are retaining too much uric acid and thus driving gout. There is more actually than this, and that really was the premise of the book that I mentioned at the outset of this lecture. Now, let's highlight these three tissues in particular in order to understand, back really to the emphasis of my talk, what is it that is responsible for insulin resistance progressing to type 2 diabetes. And to understand that, I think we need to highlight what happens at the muscle, the liver, and the pancreas. Now let's go to the muscle first. Within the muscle matters because the muscle is the main consumer of glucose. When someone has eaten a mixed macronutrient meal and glucose levels have spiked, it's the muscle that steps in to save the day. The muscle will consume up to 80% of the postprandial glucose load. So the muscle plays a primary role in regulating blood glucose levels. The uptake of glucose into the muscle uses GLUT4, the glucose transporter 4. That is an insulin-dependent transporter. Of course, muscle contraction can stimulate that process independent of insulin, but GLUT4 is the insulin-dependent glucose transporter. When the muscle has become insulin resistant, that process is compromised, and muscle glucose uptake can drop to half of what it normally is. Now, that's not difficult to see the problem. Muscle is the main consumer of glucose, and if its consumption is reduced, then blood glucose levels will be elevated. And indeed, that is an absolute contributor to the steady rise we see in glucose as someone is progressing towards type 2 diabetes. Now, if we look along the top, what we've done, I'll back that up, we have the person who's kind of right in the middle of insulin resistance, just about to start diabetes. Now we're pushing them into the diabetic realm. Now we're starting to see the glucose come up. Let's move to the liver. The liver is, of course, absolutely central to nutrient metabolism at the level of the whole body. I want to highlight two processes involved in the liver with regards to nutrients, and that is the production of fats, lipogenesis, and the production of glycogen, or the stored glucose. Insulin in a normal insulin-sensitive liver will stimulate both of these. It's both driving the production of fat and the storage of glucose as glycogen. However, when the liver becomes insulin resistant, something interesting happens. Lipogenesis is unaffected. Insulin can still stimulate lipogenesis. However, glycogenesis is compromised. And now the liver that is supposed to be storing glucose as glycogen is now ignoring insulin's heat and is breaking down the glycogen. In other words, glycogenolysis has been activated, again, despite insulin's best efforts. And now the liver that is supposed to be storing glucose, lowering blood glucose levels, is releasing glucose, compounding this fight that the individual may be having with blood glucose levels. So the insulin-resistant liver is now directly contributing to the mounting diabetes. So we take this individual who is moving ever closer towards full-on type 2 diabetes. When the liver falls, we take a significant step into that territory. Now, the last tissue I wanted to highlight is the pancreas itself. This is one that is very rarely talked about, but I argue that it is very relevant. Within the pancreas, among the myriad cells, we have alpha cells and beta cells, each of them producing glucagon and insulin, respectively. These two are a yin and yang when it comes to blood glucose, whereas glucagon is always attempting to increase glucose, insulin is, of course, always attempting to reduce glucose. Now, independent of this indirect battle they're having over glucose levels, they do have a direct effect or direct communication. And specifically, insulin from the beta cells will directly inhibit glucagon release from the alpha cells. So insulin is sort of abusive in that sense to its alpha cell neighbor, and it is reducing the production of glucagon. And that would help insulin achieve its goal to lower blood glucose. However, the alpha cell can become insulin resistant. And now insulin's inhibitory efforts are lost. And so insulin's attempting to inhibit blood glucose levels by inhibiting glucagon, and it no longer works. Glucagon release spikes, and of course, blood glucose levels will follow that spike and go up. So once again, we continue to take steps deeper and deeper into full-on type 2 diabetes. So that highlights the progression of insulin resistance to frank diabetes. But then if insulin resistance is fundamental in its origins in the etiology of diabetes, how can we fight the insulin resistance? I wanted to highlight this just because I know this is a very savvy audience, and I think that you can appreciate some of what I'll share. I strongly believe that the best way to focus on improving insulin resistance is to lower insulin itself. Now, you'll recall, of course, I emphasized what I consider 3 primary causes of insulin resistance: hyperinsulinemia, stress, and inflammation. And you would say, Ben, why aren't you focusing on the stress and the inflammation? It's because those 2 are harder to manipulate. It's harder for us to get a firm grasp on those levers to change. There may be external variables that are simply beyond our control. Insulin, I believe, is not. I think that is something that is firmly in our control, which is why I want to highlight it. So the best way to improve insulin sensitivity, I believe, is to lower insulin, and that is done by a mix of a whole bunch of things. I'll emphasize just dietary interventions and anti-diabetic drugs. Now, this is the gospel according to Ben, if you will, my personal classification of anti-diabetic or insulin sensitizing drugs, what I consider good or better options or not so good options. On the good side, we have metformin, and we have anti-inflammatory medications like, for example, low-dose aspirin. Both of those work, and I consider them good because they do work, and the side effects are generally minimal. But of course, not to say we ignore them. Metformin is the most widely used anti-diabetic drug in the world, and for good reason. It is effective with fewer side effects than normal. But as good as this best diabetic drug is, it is still only half as effective as even modest lifestyle strategies. We should never look at a drug to solve insulin resistance or type 2 diabetes, in my mind. Now, on the not so good side, I won't emphasize the SGLT2 inhibitors, although I simply only worry about them because of the consequences on the urinary tract, like infections and cancer risks. I want to highlight thiazolidinediones, or the TZDs, because they provide such an incredibly relevant example of the fat cell being at the center of insulin resistance. You'll recall that it's the hypertrophic adipocyte that becomes insulin resistant. Now, the magic of TZDs, the blessing and the curse, if you will, is that a TZD can take hypertrophic fat and convert it to hyperplastic fat. So we directly improve the insulin sensitivity at the fat cell, and by extension, the rest of the body improves. And it works. But can you see the problem? When we basically give fat cells a limitless potential, a constant vacancy sign turned on, we basically throw open the doors and allowing fat to come in and get stored ad infinitum. And the problem, of course, is that while we do improve insulin sensitivity, paradoxically, while we're improving metabolic health, we're making the patient ever more obese because we've basically given their fat cells that green light to move in more fat all the time. I consider that not a good trade-off. Now, lastly, we have insulin itself, whether it is, in fact, exogenous insulin through insulin therapy, or whether it's an insulin secretagogue like sulfonylureas. These are used because we look at diabetes, as I said, in a glucose-centric paradigm. The typical clinician will only have a regard for the glucose levels. And they will say, because glucose is all that matters, let's lower the glucose at any cost, including pushing the insulin up to potentially super physiological levels. The problem with this paradigm is that the true lethality or pathogenicity of diabetes is not based on the glucose. I'm not saying the glucose isn't relevant. I really am not saying that. I appreciate its role in neuropathies and blood vessel compromised systemic or peripheral blood vessels. But the true killers are really derivative of insulin, which I emphasized earlier when I went through all the examples of insulin resistance at tissues. Also, a study that was published that reviewed studies in type 2 diabetics looking at insulin therapy concluded, and I quote, "There is no significant evidence of long-term efficacy of insulin on any clinical outcome in type 2 diabetes. However, there is a trend to clinically harmful adverse events. Some of these adverse events are dramatic, including 2 times greater risk of cancer and 3 times greater risk of heart disease mortality." So when we give the type 2 diabetic insulin, we're making them fatter and sicker than they were before. And what do you think happens to insulin resistance? given the role of hyperinsulinemia as a cause of insulin resistance, it's not surprising for you to learn that there is evidence to suggest that insulin therapy in a diabetic makes the insulin resistance worse. They have to give themselves ever higher doses of insulin as the body becomes ever more resistant to it. I'll be bold in saying this. I think giving a type 2 diabetic insulin is similar to giving an alcoholic another glass of wine and hoping that will solve the problem. We are giving the person more of the very thing that's causing the problem. Now, diet. That was all my discussion of drugs. Let's finish discussing diet, which I believe is the most effective way to improve insulin sensitivity. I want to highlight three: a typical low-fat, the conventional thinking, the dogmatic dietary advice, low-fat diets, low-carbohydrate diets, and intermittent fasting. There is not as much published on intermittent fasting as a therapy for diabetes, but what little is there, and more is coming all the time, is compelling. This was a study that looked at a small cohort of people with type 2 diabetes who were on insulin therapy, and they each chose a different form of intermittent fasting. And you can read that citation for the details. But what was so incredible was that within just weeks, their insulin sensitivity had improved so much that they were able to stop insulin therapy. Now, in the case of a low-fat, or which is synonymous with high-carbohydrate diet, I want to highlight only one study done in the late 80s by Gerald Reaven, a legendary diabetes scientist. He took patients with type 2 diabetes and put them on a high-carbohydrate, low-fat diet that followed perfectly the recommendations of the American Diabetes Association. And he concluded, and I quote, "These results document that low-fat, high-carbohydrate diets containing moderate amounts of sucrose have deleterious metabolic effects when consumed by patients with diabetes." So we've known for 30 more plus years that the conventional dietary advice for diabetics may make the situation worse. Now, to highlight low-carbohydrate diets, I want to present data that has pitted the two against each other. In other words, clinical studies that have compared the two interventions, low-fat versus low-carbohydrate. And to explain the justification for a low-carbohydrate diet, I just want to highlight what happens to insulin when we eat these three macronutrients. When we eat fat, insulin won't change, or it may have an extremely modest effect a few hours after eating the fat. When someone eats protein, depending on a few other inputs, there can be a modest or higher than modest effect on insulin. When someone eats carbohydrate, which in nature generally occurs as a pure carbohydrate, there can be a significant insulin effect, indeed 10 times higher than normal, and stay elevated for hours. Of course, not all carbohydrates are created equal when it comes to us exploring their insulin effect. A piece of bread, for example, or a tablespoon of sugar has a very different effect than, say, a serving of broccoli. Now, let's look at what happens in humans when they're put on two different diets. This first study, let's highlight. When the patients were put onto low-carb or low-fat diets, we saw only a significant reduction in the glucose on the low-carbohydrate diet group. We saw a modest reduction in insulin, 16%, on the low-fat diet, and then we saw a 50% reduction in insulin levels on the low-carbohydrate diet. And as the studies followed up with actual measurements of insulin resistance, we saw similar reductions, where the low-carbohydrate diet had multiples greater improvements in insulin resistance than the low-fat diet did. Another study. Here are the average levels at baseline. What we found was insignificant changes in glucose in either diet. That's not too surprising. Those glucose levels are already pretty good. Insulin tended to go up on the low-fat group. It tended to go down in the low-carbohydrate group. And these differences became even more obvious with the measurement of insulin resistance, where the insulin resistance score started at 1.28. This is the HOMA score. It went up, meaning insulin resistance got worse in the low-fat group, and it went down, meaning insulin resistance got better in the low-carbohydrate group. And then the last study I want to highlight, as I'm nearing the completion of my talk, is a study that split people up. It analyzed them based on their insulin resistance, or whether they were insulin resistant or insulin sensitive. So it stratified them, or it separated them in the post-analysis based on their insulin sensitivity. And the fasting insulin levels really reveal this. In microunits, which is the US units, insulin in the insulin resistant group was 16 microunits, and then it was 5 in the insulin sensitive group. When both groups were put on a low fat diet, there was an insignificant change. Insulin didn't really go anywhere. In contrast, on the low carbohydrate diet, something interesting happened. The insulin sensitive group didn't really experience any benefit. They're already insulin sensitive, although importantly, both of these groups were controlled for body mass. So these were people of similar body weight. However, the insulin resistant group had a significant reduction in insulin on only the low carbohydrate group, low carbohydrate diet. I think there's something very relevant about these findings, which is basically that you can have some people who could respond well and lose weight on an insulin on a low-fat diet. If they're insulin sensitive, they have hyperplastic fat cells, maybe a low-fat diet is going to be the best strategy for them in just improving their overall metabolic health. But if you're insulin resistant and you're trying to improve your metabolic health, clearly there's a winner here, and that would be the low-carbohydrate diet. Now, in conclusion, how might you or those around you, patients or loved ones, be able to determine whether they are insulin resistant? I think there are 2 strategies. The first one is to look at your fasting insulin. If the fasting insulin is less than 6 microunits per mil, or in picomoles, it's less than around 40, that's a good sign. That's evidence that the person is insulin sensitive. However, insulin, like every hormone, has its own rhythm, and it's possible you'd get someone and you measure their insulin at a peak, and maybe they're in the low teens. And you would say, well, that's higher than Ben said, and that could be a problem. Well, if it's low teens, could still be good. All the more reason to look at the next measurement of insulin sensitivity, and that's the fasting lipids, the triglyceride to HDL ratio. If that dividend is less than 1.5, that's a very good sign that the person is insulin sensitive. If it's higher than 1.5, that's a warning that they likely are insulin resistant. In conclusion, I just want to emphasize the fact that we are all worried about type 2 diabetes, and rightly so, as it's increasing globally. We need to remember that type 2 diabetes is generally going to be, if not always, a consequence of a mounting insulin resistance. And it's the insulin resistance that I submit starts in the fat cell, and then it moves through the rest of the body as the first domino falls and tumbles into the subsequent domino. Thank you again for the invitation. I really genuinely hope that this has been a useful lecture, that there have been some bits of information that you find helpful and maybe even relevant to your practice. I look forward to answering any questions that you might have. And again, as I said at the outset of the talk, I genuinely hope that I'm able to give a similar talk at some point in the future with you in Israel. Thank you again for the attention. And I, again, hope humbly that you've learned something, and this has been time well spent. Thank you.
So it was a pleasure to listen to you, and it was very clear. And as a family physician, it gave me a stronger place to regard diabetes and prediabetes in a different way. And I would like to ask you a few questions regarding the clinical implication of what you said. And the first one, of course, is measuring fasting glucose, which we started to do recently, and we get results. And I would like to ask how well can we, if we get a reading, let's say 6 or 8, how can we be sure that tomorrow or the next day it will not change? Can we say that what we get is really reflecting something that is stable, and we can depend on the result?
Yes, I think that there is pretty tight consistency, assuming the blood tests are occurring at similar times under similar circumstances, blood glucose levels would be stable. So in that sense, there's a value perhaps. I would nevertheless include how relevant those numbers are in trying to predict insulin resistance. That's the problem. And so, in fact, it almost maybe becomes more of a problem. The fact that blood glucose levels are often consistent and stable under same conditions, it may tempt us to want to look at them more than we should.
So if, and again, to see how we use it, if we take, again, two college guys who are having the same lifestyle and same BMI, and now they're 40, both of them are like 28 BMI, and they are both doing a glucose test because this is what we do, and both of them are coming with 107 glucose, which is just about higher than the 100 that it's considered normal, which is not normal, of course, or not optimal. And then I do an insulin test for both of them. One would turn out 6, the other would turn out 16. Okay, what would be the difference in addressing or something like that?
Yeah, well, that's a great situation. That's a fun opportunity for me to kind of think through. So first of all, if by the time they've come in and their glucose levels have gone into the hundreds for milligrams per deciliter, then that's certainly a sign that something's amiss. And the fact that one of them has an elevated insulin, that would be the fellow where I would say, oh, how unfortunate, because we could have detected that elevation in glucose probably many years earlier if we would have been focusing on the insulin. Maybe 10 years prior, his insulin that was 16 microunits per mil now would have been 6 10 years ago. And then we would have seen it going up at each appointment. And now in the fellow who has higher glucose levels and normal insulin, I would think, first of all, that's going to be less common. But it's possible that there are other variables going on with him at that moment that I would think if his steady increase in glucose is a result of consistent dietary choices, then the insulin would be elevated similarly to reflect the mounting insulin resistance. Short of that, it could be a situation where he is experiencing stressful situations, or even something as seemingly benign as a bad night or two of sleep, and that would raise his glucose and not necessarily be pushing up the insulin at the same time. So in that sense, it might be something somewhat less dietary related.
Thank you. I'm looking at more questions coming in. What is a better indicator for insulin resistance? Would you say that the fasting or the 2 hours postprandial insulin?
Oh, that's a good question. Now, Avi, are we assuming that if we have 2 hour postprandial that we also have pre-OGTT?
Yes.
Yeah,
yes.
Well,
the
then I would say,
do we gain something by leaving the person another 2 hours, giving him some glucose, and then measuring it again 2 hours? Does it give us more information, relevant information? This is how I understand the question.
Yeah, that's a good question. Absolutely, of course, more data is always better than less. And so my answer would be a very hearty yes. In some instances at 2 hours, insulin may be back to normal, frankly. And I would say if that has happened, then that is a wonderful sign. That person's very insulin sensitive. And I won't add anything to that 2 hour time point. I would say, though, of course, following my idea of more data is always better, but I, of course, realize that is complicated. But if a person is able to get over 2 hours a blood sample and an insulin measurement every 30 minutes, 0, 30, 60, 90, 120, then there are a lot of ways. I hear a lot of discussions of people wanting to very much analyze and scrutinize the shape of that curve. But I very strongly believe that the simplest way to look at that insulin curve is just to ask, is the highest point of that curve at 30 minutes? If it is, then that's a good thing. That's a good sign that person is insulin sensitive. If the peak of that curve over those 2 hours, measuring every 30 minutes, is anywhere beyond, anywhere except 30 minutes, then that's a problem. That means the person is less insulin sensitive than would be ideal. Now, I appreciate I've gone beyond the scope of that question, but I couldn't help myself.
Okay. Our viewers really want to emphasize that SGLT1 medications have their role in treating patients, especially cardiac patients, and would like to erase it from the red list that you had. And it's important because some people have said that, so I want to acknowledge that.
Well, Avi, can I respond? Can I reply though to
Please.
I know there's no question there, but I'm going to respond to it anyway. I'm not. So SGLT inhibitors have a role, without a doubt, to very effectively regulating blood pressure and glucose very rapidly. There's no question about that. I simply think if we are having someone take a drug that is trying to push the glucose from their body, why not just limit the glucose coming in the first place? And so I guess I put that on the not so good side because I can't, the pragmatist in me thinks there's a better way to do this. If we're worried about the glucose in the middle, rather than artificially shoving it out of the body, let's just very practically address the glucose coming in.
Very good. I would say that we're talking about two different stages, and we're now trying to prevent the situation where SGLT1 would be applicable, and by trying to prevent the diabetes in the first place by targeting the insulin resistance. You talked about
Sure.
the HDL or triglycerides to HDL ratio being 1.5. Can you give us more information of where does this come from, and what's the basic thinking around that? And
Yeah,
how is it
so,
like? How does it really relate to insulin resistant as a marker?
Okay, yeah. So insulin very, very strongly has a role in lipid handling at the level of the liver, and I touched on that in my talk. But insulin is always promoting the formation of triglycerides that would be sent around in the triglyceride-rich VLDL and then LDL. And insulin reduces HDL. So in that sense, hyperinsulinemia reduces HDL. So in that sense, insulin is directly altering those two variables. And then there's just correlational evidence in humans to show that triglyceride to HDL ratio correlates very well with markers of insulin sensitivity, including the HOMA score and including data derived from hyperinsulinemic euglycemic clamps, which is a very good way of measuring insulin sensitivity. Now, having said all of that, I am compelled to add that ratio it starts to can't maintain its fidelity across all ethnicities. There was a study that highlighted that the triglyceride to HDL ratio is not as valuable in an African population. So there are limitations to that ratio that I sometimes I'm not quick enough to admit. So I'm admitting it here. There are, however, there is a growing body of evidence to suggest that there's a more broad lipopanel or lipid panel and lipoprotein analysis that is used that actually has a better predictive power than the triglyceride to HDL ratio alone. And so that's a growing area. There was a manuscript just published recently that touched on this. I can't remember what they're calling it, but like the Lipo IR score or something like that. But the theme of it is it's that blood lipids are more and more reliable marker of insulin resistance.
I see we're kind of running out of time. There is a question about HOMA. If you can give us, there is the percentage of B, percentage of S, and the IR numbers. Can you elaborate a little bit about these three numbers and how do we read them, or how do we understand them to understand better insulin resistance?
Yeah. So HOMA is a term that it can be used to encompass a few aspects of insulin, including insulin secretion, insulin release, or insulin function, glucose responsiveness at the beta cell. When I'm invoking HOMA as a marker of insulin resistance, and I think it's a good one, I'm talking about HOMA-IR. And I think it's valuable simply because it forces the clinician to focus on both glucose and insulin. And that is always a good thing. So the fact that HOMA is including insulin, I think, is a strength. And HOMA has the benefit of we have a better idea of clinical cutoffs, whereas fasting insulin is still very much debated. What would be considered a normal range. A person can get a blood test and get their fasting insulin measured, and someone, depending on the clinic or the lab, it will be considered normal anywhere from 1 to 30 microunits per mil. And I think that's crazy. But HOMA has been looked at long enough that it has some more consistent cutoffs, where if a HOMA score is under 1.5, that's generally considered very good. If it's between 1.5 to 3.9, that's considered insulin resistant. And then 4 and above is that your things are so bad that it's type 2 diabetic. There are problems, of course, with that a little bit, and I would appreciate anyone challenging those cutoffs, but those tend to be the general clinical points.
Thank you. And lastly, before I pass on to Dudi Dvir, my friend, people are really interested to know GLP-1 and DPP-4. How would you refer to them, especially the sense of treating insulin resistance?
Yeah. So I really meant to add GLP-1 receptor agonists in particular. So the interesting thing with both of those drugs is that they come in the wake of interest in the intestines. And this actually was played out in my PhD lab. My PhD mentor, Linus Dome, and a bariatric surgeon, Walter Porres, were really pioneers in this regard, trying to find these incretins, or these gut hormones that change so wildly in gastric bypass, and how they influence insulin sensitivity. So the interesting thing about GLP-1 receptor agonists, which I can speak to with more authority, they are insulin secretagogues, like sulfonylureas. And in general, I would say that is, in my book, and again, of course, I'm not a clinician, so in the sterile halls of academia, I would say I'm not a fan of insulin secretagogues. GLP-1 receptor agonists have the advantage that while they do kick the pancreatic beta cells into producing more insulin, which I don't believe is valuable in type 2 diabetes in general, they also do have some of the systemic effects of glucagon itself, and which is generally very favorable when it comes to glucose use and weight loss. For example, GLP-1 receptor agonists stimulate the actions or activity of brown adipose tissue. And when brown adipose tissue is stimulated from these molecules, they become enormous. Well, despite their size, they punch above their weight. They really consume glucose very rapidly. And of course, in so doing, help lower blood glucose and help the body be more insulin sensitive. So I do think I have a warmer view of those two drugs, but in particular GLP-1 receptor agonists, than I do others. Even though I say that, and I'm somewhat biting my tongue because I don't generally like the idea of pushing insulin higher than it already is in the case of a type 2 diabetic.
Thank you very much, Dr. Bikman. Dudi.
My pleasure.
Let's hear the
Hi and good evening. Thank you, Dr. Bikman, for interesting presentation. And thank you, Avi, for leading the question. My name is Dudi Dvir, and I'm a family physician and head of primary care division at Mu'chedet, an Israeli HMO. I am very excited to be here, and I would like to thank Mariela for inviting me to this panel. Jerry Raven, not long ago, 1988 Banting lecture, which was where he first generated the interest in insulin resistance, not only leading to diabetes, but also hyperlipidemia, inflammation, elevated uric acid, polycystic ovary, and cancer. Insulin resistance as continuum, starting with hyperinsulinemia and leading to impaired glucose disposal, metabolic associated fatty liver disease, and eventually type 2 diabetes. The foundation upon which the major 3 chronic diseases sit in addition to the dire complication of diabetes, the majority of diabetes-related mortality comes through amplification of atherosclerotic disease, cancer, and dementia. And I think that it's a fascinating syndrome, and going into it, and I would like to present the distinguished panelist, Georgia ADMD, is an Harvard-trained board-certificate psychiatrist, specialized in nutrition, science, brain metabolism, and mental health. She has 2 decades of clinical experience, including many years as a college psychiatrist and nutrition consultant at Smith College and Harvard University Health Service. Dr. Volek is a registered dietitian and professor in the Department of Human Science at Ohio State University. His translational research includes 300 peer-reviewed manuscripts and 5 books. The Volek Lab is focused on basic and applying human response to dietary carbohydrate restriction and nutritional ketosis. And finally, Dr. Mariela Glandt, trained at Harvard and Columbia, is an endocrinologist with extensive experience in treatment of diabetes. She is the founder and director of Glandt Center for Diabetic Care in Tel Aviv, which specializes in optimization of diabetes care through use of very low carbohydrate diet. So with this distinguished panel, we will begin. And first, the question is for all of you. What is insulin resistance for you? So we will start with Georgia.
What does insulin resistance mean to me?
Yeah.
So I actually really enjoyed Ben Bikman's talk. It was excellent, and I highly recommend his book as well. I think he did a beautiful job of explaining it. And really, the cells which are so reliant on insulin. Insulin is so much more than a blood sugar regulator. And this is still, unfortunately, how most clinicians and most of the general public view insulin. It's a master growth hormone. And every cell uses insulin for a wide variety of things. And so if insulin isn't working properly, if cells aren't responding to insulin properly, there is no end to the number of things that can go wrong. And every organ is affected, including the brain, including perhaps especially the brain. And so that's my area of interest. But I view it as the sort of the energy regulation system of the body really falling apart. And all cells require energy to function properly. And so if energy isn't being regulated, if energy can't be delivered properly to cells, then those cells will not function properly. And as I said, just about anything can result. So I view it as public health enemy number 1, insulin resistance.
Thank you, Mariela.
I think of it probably very similar to what Ben said, which is the body, basically the fat cells are overstuffed. The body's saying, stop, I can't take this anymore. I have more energy than I need. And this translates, and since insulin is the hormone that brings in the extra food into the fat cells, the process starts. Well, we're rejecting that insulin. We don't want to respond anymore to this hormone. Of course, the person doesn't know this. They keep eating the banana or whatever it is that requires insulin. But now this becomes a vicious cycle where the pancreas now has to secrete a lot more insulin, and over time, to overcome this resistance. And over time, the insulin starts to be high even when you're not eating. And this leads us to, as Georgia said, to an energy dysregulation.
Thank you. Jesh?
Yes, first, let me just say thank you for the invitation to be on this panel. And I will echo many other comments. That was a terrific talk by Dr. Bikman. And I would say our views of the pathophysiology of diabetes and insulin resistance are extremely well aligned. But when I think of insulin resistance, first of all, I'm a bit humbled at the complexity of the molecular details. And many scientists have made careers studying it, and we still don't understand a lot of it. And we won't for quite a while. The good news is when I view insulin resistance as manifesting functionally as a form of carbohydrate intolerance. So when you view it from that perspective, you don't necessarily have to understand exactly what's happening at the cellular level and the molecular details, but the fact that it is a carbohydrate intolerant state, which means type 2 diabetes is not just a disease characterized by insulin resistance, it's a disease that manifests as carbohydrate intolerance. And viewed through that lens, the solution becomes pretty simple, that limiting the carbohydrate it effectively manages and indeed reverses the condition. And so that includes prediabetes and metabolic syndrome, which you might view as earlier, milder, more widespread versions of carbohydrate intolerance or insulin resistance. They're quite effectively treated with carb restriction. So in terms of a model and in terms of explaining insulin resistance, I like to think of it in that way. And there's enormous amount of evidence to support that when people increase their carbohydrate intake, they begin to take on signs and symptoms of insulin resistance, and vice versa. When they limit carbs, they go in the other direction, they get better. Now that sort of sliding scale, if you will, of carbohydrate intake, there's no single level of carbs in which you trigger this process. Everyone's a little bit different, and that's sort of the basis for individualizing carbohydrate intake. But I'll just add that ketogenic diets are uniquely therapeutic, in part because they're very low in carbohydrate and they address this carbohydrate intolerance phenomenon. But we're also now understanding that ketones themselves are not just alternative fuel and in fact preferred fuels for the brain and the heart, but they're potent signaling molecules. So there's some unique benefits of the ketogenic diet that are in part attributed to the ketones themselves, which are robustly impacting cellular function, including addressing inflammation, oxidative stress, having immunomodulatory effects.
Thank you. Georgia, is the expression of insulin resistance different in the brain?
Yes, it's really fascinating how insulin resistance manifests itself in the brain. Whereas in many parts of the body, insulin acts as an important key to unlock cells and let glucose in, it's not the case in the brain. The brain is so dependent on energy; it's an energy hog. Despite being just 2% of the body's weight, it requires 20% of the body's energy supply. So it can't afford to have anything interfere with its access to glucose and ketones. So what happens when a person becomes insulin resistant in the body, in the periphery, is that the blood-brain barrier, the cells on the surface of the blood-brain barrier also become insulin resistant. The brain does not become resistant to glucose. In fact, even no matter how high your blood sugar goes, your brain sugar will also rise proportionally. So the higher the blood sugar, the higher the brain sugar, even up to 400 milligrams per deciliter, this has been shown. So even if you have severe insulin resistance or type 2 diabetes, you never need to worry about low brain glucose. What you need to worry about is low brain insulin, because the more insulin resistant you become, the more difficult it becomes for insulin to cross the blood-brain barrier and enter the brain. And this is a huge problem, because without adequate insulin, brain cells cannot process glucose and turn it into energy or use it for anything else. And this is really the foundation of many cases of Alzheimer's disease, which is now often called type 3 diabetes, which is that you can literally, your brain can be swimming in a sea of glucose and still be starving to death because there isn't enough insulin. So it's a very different situation from the rest of the body, and really critically important.
Thank you. Mariela, Jeff talked minutes ago about the dose response in restricting carbohydrate. And how do you see this? And is there a special role for ketones?
Yes, I think there is a special role for ketones. I think that they're not just a fuel source, but as you mentioned, Jeff, it's an anti-inflammatory molecule. This is something I learned from you, Jeff. And I think it's, and since the pathology of insulin resistance is also linked to inflammation somehow, like you said, unclear exactly how everything works, but definitely we want to lower inflammation. And I think that there's definitely a benefit of going all the way. I mean, definitely in clinical practice, we know that going low carb can be helpful for many people, but a lot of people are frustrated. And it's not until you go all the way and you actually start limiting carbs in a very extreme way that you actually see difference. We know that fat oxidation is very, very sensitive to insulin levels. So we want to really push that insulin level down as far as possible. And this really leads to clinically significantly improved results. So I really do see a huge difference between going low carb and going keto.
Mm-hmm. Jeff, can you summarize what is a well-formulated low-carb diet or ketogenic diet?
Yeah, sure. Well, fundamentally, a ketogenic diet, as the name implies, results in higher levels of ketones, increased production of ketones, primarily in the liver. And the primary factors that control endogenous ketogenesis are the carbohydrate and protein in your diet. So as most people understand, a ketogenic diet needs to be restricted in carbs. That's number one. To what level? It does vary, a lot between people, but on average, it's about 40 grams per day. But geez, we work with some athletes that are highly insulin sensitive that can be in ketosis with more than twice that amount of carb. And at the other end of the spectrum, you've got more insulin resistant type 2 diabetics who need to be below 30 grams per day. So there is some variation there, but it also is impacted by the protein being anti-ketogenic. So you really need to be in a sweet spot with protein because you don't want to be deficient in protein, even though that would enhance your ketones. Obviously, you would lose lean mass and functional tissue, which is not desirable. So there is a sweet spot of protein that we generally would prescribe somewhere around 1.2 to 1.5 or 1.8 grams per kilogram ideal body weight. And we use ideal body weight so that it's not overprescribed in obese people. So getting the protein right, getting the carbs right, that's where we really start in terms of, getting the ketones up and into the range of nutritional ketosis. And fat quantity, we don't spend a lot of time teaching people how to find a magic number or eat a specific amount of fat. We focus more on the quality. And with the ketogenic diet, fat is becoming your primary fuel. And polyunsaturated fats, it turns out, are not great fuels. So from a dietary perspective, we're encouraging people to eat primarily monounsaturated fat sources, so avoiding corn oil and most of your plant-based oils, safflower oils, and so forth, and focusing on natural forms of fat, which are typically relatively low in polyunsaturated fats. And we're telling people to eat to satiety. So in obese people, when they get into ketosis and get these factors right, they naturally limit calories, and weight loss is more or less less effort. There's greater satiety, and it's just easier to lose weight, lose body fat. There's also, you need to recognize certain changes in your mineral balance, and the way the body handles sodium is really important. So ketosis is associated with a natriuresis, where the kidneys go from retaining sodium on a higher carb diet to excreting more sodium. So you do need to pay extra attention to compensating for that additional sodium loss in the urine, and making sure there's adequate sources of potassium and other minerals. And that's where food selection and variety come into play, to make sure that you are getting all the essential micronutrients. And a well-formed need to supplement, not that that you can't, and under certain conditions there might be a place for supplements, but the point is the diet is not inherently deficient in any essential nutrients in the context of a well-formulated ketogenic diet.
Thank you. Georgia, can you share with us a little bit about your experience treating mental health problem with ketogenic diet, low carb diet?
Yes, so I've worked with hundreds of patients using ketogenic diets and some other forms of dietary interventions as well, but primarily ketogenic diets. And I'm a general adult psychiatrist, so I treat all comers. From ADHD to depression to bipolar disorder to psychosis, etc. And what I have discovered is that, and it's no surprise, I think this won't surprise anybody, is that these diets can be, as Dr. Volek was saying, uniquely healing. They have uniquely healing properties all across the board. And again, so if you're improving brain metabolism and you're improving dietary quality, then you are improving the overall health of the brain. And that has the potential to improve any condition you walk through the door with. It certainly doesn't help everybody, but it helps most people. Some people are completely able to avoid or discontinue psychiatric medication. And some people are able to significantly reduce the amount of psychiatric medication they are taking, either the dosage or the number of psychiatric medications they're taking. And this is, for me as a psychiatrist who's been in clinical practice for 20 years, you don't see that. When you use conventional treatments, when you use medications and psychotherapy, it's really very disappointing to see how few people improve. In fact, most people, because of the medications that we prescribe, become less healthy over time. Many of the psychiatric medications, in fact, induce more insulin resistance, can raise blood sugar levels, can raise appetite, can cause significant metabolic dysfunction and weight gain. And because so many of the psychiatric illnesses we know do have some connection to insulin resistance, the studies are still to be conducted to really understand the connection. what we're actually doing is we're prescribing medications that can make the underlying syndrome worse. So when you prescribe ketogenic diets, and particularly, as I was going to really agree with Dr. Glandt on this, is that there's a huge difference in clinical practice between a low-carb diet and a ketogenic diet. Most people who are eating a low-carbohydrate diet are not in ketosis. And this makes it, this really is clinically an enormous problem for a lot of people who are hoping to get more benefits. So when you're working in the psychiatric space, and someone says, well, I got worse on the ketogenic diet or I didn't get better, 9 times out of 10, they were never in ketosis to begin with. And I would like to say that some people do improve on a simple low-carb diet because that's lowering and stabilizing glucose levels, and that's decreasing the glucotoxicity effects on the brain, which are really significant. But being in ketosis helps a lot more people because then you're also managing that energy gap where the brain has become somewhat unable to a certain extent to metabolize glucose. You're filling in that energy gap with ketones, which, as has already been said, they're not a backup fuel. Ketones are the preferred fuel for the majority of the brain, not the entire brain, but the majority of the brain. So in clinical practice, what I see is, people being able to reduce the amount of medication they're taking, feeling better than they felt in 30 or 40 years, being able to avoid hospitalization, having suicidal ideation that has been there for decades on and off disappear. People able to come off stimulant medications who are taking stimulants for ADHD, people able to lower or avoid or eliminate their mood stabilizing medications for bipolar disorder. I mean, every day I see people getting better in ways neither one of us could have ever expected had we used any other approach. So it's this, in addition to it just being a really powerful biochemical intervention, it's really empowering because instead of people becoming more and more dependent on medications, which aren't serving them particularly well, they become, they feel like they have more control over their mental health. And, maybe it's not about their childhood. Maybe it's not about some trauma. Maybe it's not a character defect or a weakness. Maybe it's as simple in many cases as being given the wrong information about how to feed the brain properly.
Did you see any kind of side effect to this treatment? Is any kind of danger or treating ketogenic diet to mental aid patient?
Yes, so it's actually very complicated clinically. That's one of the reasons I actually teach a course now for clinicians who are interested in learning how to use this therapy, because there are very important things that people need to know if they're going to use the ketogenic diet to treat psychiatric disorders, especially if the patient is taking any kind of psychiatric medication. And so one of the challenges with mental health is the keto adaptation period itself can be much more challenging for people with mental health conditions than for people without. So you can see for the first 2 or 3 weeks, in many cases, you can see people becoming worse, more depressed, more anxious, more agitated, even manic or hypomanic in some cases. I have a lot of theories about what I think is going on there, but really this transition is in the vast majority of cases temporary, and it can be made worse depending on the medications that they're taking. So there are some things, and the medications need to be managed very carefully and monitored very closely because the levels can change in some cases. And this is not a fault of the diet. This is the fault of the medication. So there's a lot of experience and knowledge that needs to be brought to bear. But let me just say that there are two wonderful things to know about this. One is, if someone decides to try, if someone listening out there at home with a mental health condition or someone in your family wants to use a ketogenic diet to try to treat a psychiatric issue, if you're not taking psychiatric medication and you do not have serious symptoms, you've never been in the hospital, you've never been at risk to yourself, anything like that, it is very safe to embark on a ketogenic diet so long as you're not taking any medications. And if you notice any problems, if you start to feel worse in any way, and it feels unsafe or unbearable, all you have to do is eat some carbohydrate, and within an hour you'll be fine. So that's your plan B. But if you're taking medications, or if you're working with a patient who's taking medications, it is a very different, just as is in the field of diabetes management, just a different ball game, because you really do have to know what you're doing with the medications. But I think the good news is that more and more people, more and more clinicians are learning how to do this, and more and more patients are demanding these kinds of services, because the psychiatric medications have been really a disappointment for so many people. It's not to say that there isn't still a role for medication. Medications can be very helpful and still can be need to be part of the long-term plan for some people, but any reduction in medication is a victory. And if you're taking a psychiatric medication, which is causing metabolic issues or causing you to feel sedated, causing, really sleepy all the time, groggy, brain fog, can't concentrate, you've gained 30, 40, 50 pounds. If you add the ketogenic diet to the medication, even if your goal is not to come off that medication, you would feel and be so much healthier on the medication. And that in and of itself is also a huge victory. So I think it's a field that is just tremendously exciting and hopeful. And I do think it's really worth everybody exploring this piece of the puzzle.
Thank you. Mariela, is there importance for early detection of insulin resistance? How do you see this? If we have to treat very early, if we can wait for a patient become a little bit worse, so how do you see this?
I think it's a no-brainer. At least if we look at the diabetes information, we know that people who want to reverse their diabetes after 30 years with keto have a harder time than people who have just started having diabetes. So I think this is true for bariatric surgery. It's true for when we see this in general. I see this also in my practice. And I believe that we also see this in the Verta trial. Jeff, correct me if I'm wrong, but I think it's about 8 years on that we see still reversal in the Verta trial. I have to review that data, but I definitely know that the longer you've had high blood sugars, so there are two factors here that matter. How high your sugars have been and how long your sugars have been high. So this is really extremely determining. So that's why when I see patients that are coming in after 30 years with high blood sugar and they want to be on no medications after a month, I say, forget about it. That's totally unrealistic and it's not going to happen. If we're talking about a patient who is just diagnosed now, then I think that the chances are really high that we can get there very quickly. So it really matters how long you've had this. Now, this is for diabetes. Now, you're asking in general about insulin resistance. And yes, we're talking about how insulin is a growth factor, how insulin causes growth also at the arterial level, how it influences the kidney. We do not want, we see microalbumin, which is one of the manifestations of high insulin levels from a few small studies that I've seen. And I see how beautifully the microalbumin goes down by just lowering the insulin. So I feel that on whatever organ you're looking at, you want to lower those insulin levels and as soon as possible. The problem is that physicians are not aware. Like Dr. Bikman talked about these signs, but most doctors, I'm surprised, they can look at an HDL of 40 and not blink. Okay, they have a triglyceride of 150 and an HDL 40, and they don't react. And to me, that's screaming insulin resistance. Because if you talk about that ratio is much, much more than 1.5. And immediately I say, we have insulin resistance. If metabolic syndrome is characterized as having 3 out of the 5 things. Sounds off. Anyway, 3 out of 5: high triglycerides, low HDL, increased waist circumference, hypertension, and dysglycemia. So I don't want to wait till you have 3 out of 5. If you have one of them, say hypertension, to me that's already a sign to start acting. I believe in earlier is better, And I think that one of the reasons we are doing this conference at all is because I think we need to bring awareness to the family practice doctors, to clinicians in general, to wake up and recognize insulin resistance early. This is where it's at. So, yes. The short answer is yes, early is better.
Thank you. Jeff, in Dr. Bikman presentation, he talked about SGLT2, and we know that they have a good influence on the heart. What is the current research on ketone and the heart? What are you seeing in your labs and other research?
Well, I'll say in general, there's a lot more interest in how ketones impact cardiac function. I mean, we've moved from ketones being toxic metabolites of fat metabolism to now being superfuels, and so it's really an exciting time. However, we really don't have clinical trials now specifically in patients with heart failure or cardiovascular disease. So we're still waiting. We still have some time before we have definitive answers. But there's a lot of different lines of evidence pointing to ketones being very positive on heart function. For example, some of the basic science is showing when the heart is fueled by ketones, it's more efficient. So it's generating greater work, and more ATP per unit oxygen when it's fueled with ketones. And there's some provocative studies now that have looked at ketone infusion, to acutely elevate ketones, and that has been shown to have a profound effect on cardiac output in both healthy and patients with compromised ejection fraction and heart failure. So those lines of evidence are really encouraging. The heart is much like the brain in that it will preferentially take up ketones in direct relation to their concentration in the blood. So there's no doubt that when you're in ketosis, the heart is utilizing ketones. So the next question is that what does that do? And again, the evidence is pointing towards some positive effects. And now the SGLT2 inhibitors, there's multiple trials now showing long-term benefits in heart failure and having good evidence around decreasing hospitalizations, morbidity, mortality. The mechanism by which they're having those positive effects is still being debated, but they do moderately elevate ketones. And so that could be one mechanism by which they're exerting those positive effects. And that has really opened up the eyes of cardiologists who've been historically very skeptical, to put it nicely, about ketogenic diets and long-term impacts on cardiovascular disease. So I do think there's a high priority and a need to really study this in as a secondary prevention, perhaps, in patients with various cardiovascular diseases. But we're not quite there yet. But I'm highly encouraged by the data that we do have.
Thank you. Do you have any experience in using exogenous ketone treating mental illness, or you use them? You know about this?
Yes. So this is, I always, of course, encourage people to generate their ketones from inside the body whenever possible as their primary strategy. But there are some patients who cannot do that for a variety of reasons. especially older individuals who may be, living in so for example, an assisted living situation where they don't have total control over their meals, for example, lots of different situations, and some people who simply do not want to or refuse to change their diet. And so exogenous supplements of MCT oil, which many of my patients use, especially my older patients who are, struggling with cognitive decline, can be a really wonderful support for. I always, of course, encourage them to do the ketogenic diet, but the MCT oil helps boost that ketone level by a few, usually between just maybe 0.3 millimole or so, but it makes a difference, and it also helps with satiety. It helps people feel full, and it really does seem to improve cognitive function to a noticeable extent, small but noticeable extent in a lot of my patients. MCT oil does, if they can tolerate it, because there can be some gastrointestinal distress with MCT oil. Some of my patients also use exogenous ketone salts. For a variety of different issues. I find them very, very helpful in people with food addiction or binge eating disorder who have, or anybody who's kind of fallen off the diet, either intentionally or accidentally, in helping them get back on track the next day, and sort of, again, suppressing appetite, improving how they feel mentally and emotionally with that little bit of a ketone boost. The better brands can, raise your ketones by, anywhere between 0.3 and 1 millimole, and that can make a big difference for people especially when they're trying to get back on track, which will support a fast. And then there are, of course, the ketone esters, which are, the salts are quite expensive, but the esters are even more expensive. And something interesting I've noticed about the ketone esters, that's just a pure beta hydroxybutyrate, other than them being, costing a fortune, is that they raise ketone levels so dramatically, sometimes by several millimole and very quickly. And again, all of these supplements, not again, for the first time I will say, all of these supplements only last, a maximum of 2 hours in the body. So any of these strategies you would have to, use multiple times per day, which makes MCT oil the really only affordable way to do this. But the ketone esters, which are purified beta hydroxybutyrate, those can raise ketones so dramatically that they can really clear people's, really clear their mind and give them a big mood and energy boost, very temporary, of course. But interestingly, in my experience, they seem to, they can sometimes suppress the body's own ability to generate ketones for the rest of the day. It's almost as though the body is seeing those come in and say, okay, well, we could just go to sleep. We don't need to make any ourselves. And so that's very, very interesting pattern that I've noticed. But I use those types of supplements if people can afford them, just for special occasions, like someone's studying for a professional exam or has an important deadline at work and they really need a really reliable ketone level that day. Otherwise, I really encourage people to generate their ketones from inside the body, because the exogenous ketones do not lower glucose and insulin levels. So you can take the exogenous ketones and they will help you with symptoms, but they will not do anything for the underlying disease, which is marching on. And so as soon as you stop that supplement, the disease remains the same, if not worse, because you haven't addressed the underlying issue. So, but they certainly can be helpful, particularly as a supportive strategy in combination with a ketogenic diet.
Thank you. Jeff, the usual recommendation for combating insulin resistance is diet and physical activity. Can you compare physical activity to a ketogenic diet as a tool for this? If we can compare these two ways to combat the insulin resistance.
Yeah, that's a really interesting question. I guess, one way to approach that would be metabolically. Both exercise and decreasing carbohydrate intake, especially ketogenic diets, are stimuli to increase fat oxidation, increase lipolysis, increase systemic ability to utilize fat. But comparatively, ketogenic diets are much more potent. When an individual keto adapts, they essentially double their rate of fat oxidation. They go from basically utilizing a mix of carbohydrate and fat to burning almost exclusively fat at rest and during submaximal exercise. And that's true if you're an elite athlete or if you're a type 2 diabetic. Proportionally, you dramatically reduce your reliance or dependency on carbs and accelerate your body's ability to burn fat. But comparatively, ketogenic diets are much more potent than exercise, and it's additive, so that elite athletes that are already good fat burners become extraordinary, prodigious fat burners. But they are complementary in many ways. I mean, exercise is a very complex, exercise science is a very complex field, so it has improves health in a lot of different ways. But I guess I'll just mention one thing. I mean, when we work with especially diabetic patients and obese patients, and this is a little controversial, especially because I reside in a kinesiology exercise science department. We're not prescribing exercise right off the bat. And part of the reason is, for an obese person, exercise is punitive. I mean, it's painful. Their metabolism is broken. So to ask them to exercise, there's not a lot of satisfaction in that, and they usually fail at it. Not to mention, they probably already have some chronic low-level inflammation, and exercise can be an inflammatory stimulus. So, we really focus on mastering the diet and fixing their metabolism. And I think Dr. Eads mentioned the diet's very empowering, and I couldn't agree more. I mean, and in that way, they get some weight off, their fuel is flowing better, and you're actually then enabling them to want to exercise, and they're able to exercise and get the benefit from exercise. But it's not something we push right away. We kind of let people decide when to incorporate it into their lifestyle, as opposed to burdening them with having to do that as well as change their diet up front. Doesn't always work very well.
Thank you. Mariela, if we ask a physician about ketogenic diet, they said that the biggest problem is the LDL cholesterol. And that this is because of that, they don't recommend this ketogenic diet. What is your opinion about it?
$1 million question. My opinion is this. We know that the biggest risk factor for cardiovascular disease is actually insulin resistance. And it's high triglycerides, low HDL. Again, I go back to the same stuff that we should be paying attention to. But it's the low insulin, it's the high insulin that's driving the cardiovascular disease. This is, like Georgia said, public enemy number one. This is what we need to be dealing with. Of course, what confuses the matter is that we have to look at what context is the LDL in. If LDL does go up in this diet, I see it all the time, okay? And the more healthy you are, the more metabolically healthy you are, the more the LDL goes up, okay? When I see a thin, fit person walk in, I'm like, oh no, it's probably the LDL up being really high, that this is gonna be the question. Because this is the healthier, the more fat that needs to be feeding your cells, and more LDL going around trying to carry this to feed your body it's part of the territory. The issue is that if you have high LDL in the context of metabolic disease, then yes, we should be very worried. The high LDL, when you are in the context of high triglycerides, low HDL, is concerning. So what we're trying to work on is let's fix the underlying disease and then see what happens to the LDL. If the LDL is high, but in the context of very nice metabolic milieu, then I worry much, much less. And actually, I don't worry because we know from trials that this diet increases the LDL size. And we know that the big LDL is not associated with cardiovascular disease. So this is very nuanced. Of course, we need the big trials to actually show the mortality data. And we're all waiting to one day see this. But in the meantime, I think the proxies are so, so powerful that I feel confident that we're actually improving the cardiovascular risk factors for the patient, even though the LDL goes up. Because what goes up is doesn't it go again?
Thank you very much. It was a very interesting conversation. I learned very much. And Mariela, it was a wonderful evening. Thank you.
Thank you, guys. Thank you so much. So I'll continue here and tell you guys, first of all, Georgia and Jeff, so grateful for joining us, and Dudi for leading this. And for the rest of you, we'll see you next week. We have also an amazing lecture series planned. Don't miss it. February 18th with Nina Teicholz. So, and an amazing panel following this. So we will see you next week. Thank you so much, everybody.
Thank you, everybody.